Okay, مساء الخير عليكم جميعا. Good evening everybody. It's already 6 p.m. in Riyadh time, which is GMT +3. And I wish everybody now is able to join. Last week, we already discussed the topic of gummy smile and how to differentiate the causes of and diagnosis of the gummy smile itself. So today, I'm going to talk about the aesthetic crown lengthening. Usually in our clinics, a patient came to us and they are asking about a treatment. And usually they ask about a specific thing to do, but they don't know what other treatments are connected to the treatment they are asking for. So most of our patients came and they are asking for a new smile. And this is really a dilemma in the relation between the patient and the dentist. Because usually the patient asking about this treatment or this smile makeover without knowing the background of these treatments and how it was done. And they saw our treatments, or let's say before and after treatments on the social media, but they didn't know exactly what happened in the middle. Like in these two cases, most of the patients, they just see the after and they wonder what happened exactly in this case, but they just want to do the same, but they don't know what exactly was done. And in most of these cases, it's not a one-man show. It's not my show. It's not the prosthodontist show or the orthodontist show. It's a teamwork. So in most of these cases, there is a teamwork. If the patient is lucky, it will be a periodontist work and the prosthodontist. If the patient is less lucky, he will have additional orthodontic treatment, like in this case, periodontal work and also prosthodontic work. Or the case on the right, it was only a periodontal work and then the prosthetic work. But in order to reach to this type of a treatment or this level of a treatment, we dentists need to discuss these cases with the patient first. We need to understand and let them understand what exactly is the steps before they start the prosthodontic work. And at the same time, we as a dentist, we need to know where we are going. Okay, what is the end result? Because before you start, you need to know where you are going. What is the end result that you are expecting from these cases? And this again leads me back to just one slide in order just to revise things with you before we start. The periodontium, as we discussed before in our last lecture, is composed of 4 compartments, which is the gingiva, periodontal ligament, alveolar bone, and cementum. So going from inside, cementum, periodontal ligament, the bone, and then the gingiva. And in crown lengthening surgeries, it is well known that we can only deal with the gingiva and the bone, while we are not allowed to cut anything with the periodontal ligament inside or touch the root itself. So we should deal with the gingiva and the bone, and we should not deal with the periodontal ligament and cementum. This is the first line that we need to know first before we go on. But before we start also, this lecture is all about this slide. And we are going to discuss this slide step by step. And then we will jump to the treatment itself. But before we jump into the treatment, we need to understand all of these points together. And you will keep seeing this slide every while and then to remind you that these 10 points, I summarize it as minimum 10 points that you need to look after before you even start any crown lengthening surgery, either for one tooth or for the complete anterior segment or whatever is the teeth that you are going to do crown lengthening for. So let's start. The first point is you cannot start until you understand this point. The first point is what is the minimum attached gingiva needed? But let's first also know what do we mean by attached gingiva. Also, I think we discussed this point before in the last lecture, but I'm going to revise it very fast. We have the marginal gingiva here, well known, it's about 1 millimeter. And then we have amount of attached gingiva here, okay, which is keratinized, okay. and then we have a line called mucogingival line that separates the attached gingiva from the alveolar mucosa, and then we have the alveolar mucosa. So this part is keratinized while the alveolar mucosa is non-keratinized. So what is the significance of this slide? This slide shows you that we have amount of gingiva, not alveolar mucosa, only gingiva here, that we are allowed to deal with. And from this attached gingiva, we need, after we finish our surgery, after we finish our crown lengthening, either by laser or by osseous surgery, we need to keep in mind that minimum of 3 millimeters has to be kept into this attached gingiva. And why we need this attached gingiva? This attached gingiva is needed because most of the masticatory forces, oral hygiene measures that the patient is doing while brushing, while eating hard food, depends on how much attached gingiva you have. So the amount of attached gingiva, what is it exactly? It is the distance between the marginal groove, which is after the marginal gingiva here, we have a marginal groove, we have the attached gingiva, and then we have the mucogingival line, and then the alveolar mucosa. This part is called attached gingiva, and we need, after we finish, to end up with 3 millimeters, and we need to check this amount of attached gingiva before we start dealing with the case. So how much we have of attached gingiva? Exactly. Is it 3 millimeters, 4 millimeters, 6 millimeters? How much exactly we have from this attached gingiva? So, like in these cases, if you just check one of the cases, and it's, by the way, general, most of the patients, they have in the upper maxilla, in the maxilla, they have the widest attached gingiva amount on the anterior area, while they have the narrowest area of attached gingiva around the premolars here. In the lower jaw, it's opposite. We have the lowest amount of attached gingiva in the anterior area, while the widest amount of attached gingiva is on the molar. And that's why most of the cases that they have recession, they have it either on the lower anterior teeth or canine premolar and premolar area in the upper jaw. That's why when you place veneers on the lower jaw, you will be facing more problems than you are more problems in the anterior area than having problems in the upper maxillary anterior teeth. Okay? So the first point we discussed it was how many attached gingiva we have. The second point is the tissue biotype. And what do we mean by the tissue biotype? It is the type of the tissue that we have. So we have either thick gingival biotype or we have thin gingival biotype. And this is also another important factor to know about the attached gingiva that you have. Is it thick or is it thin? And if you have a look on these two slides, you can notice that the thick gingival biotype, the teeth shape is even different, the papilla shape is different, and even response later to any treatment, surgical or by laser, or even by doing a filling or a veneer over these teeth, will have a different response. In most of the cases in which we have thick gingival biotype, we have something called rebound effect, which means that if we cut the gingiva, this thick biotype has the tendency to go back to its original position. While in the thin biotype, if you cut, let's say 1 millimeter, expect to have another 0.5 up to 1 millimeter of recession, because the type of gingiva will tell me exactly what is the reaction from the gingiva after I cut, if it is a thick or thin biotype. So, first point was attached gingiva and what kind of is attached gingiva we have. The third point is, where is the bone? You know, under the gingiva and alveolar mucosa, we have the alveolar bone. And where exactly is this bone? We all know that teeth are inserted in the maxilla and mandible in part of the jaw, which is called alveoli. What is, sorry, let me go. What is specifically, what is the clinical factor or the clinical value of this alveoli? Usually the teeth are inserted inside the bone with fibers going into the bone called Sharpie's fiber or bundle bone, okay? So that means that the bone there is perforated as you can see, when the tooth is inside the socket, after you extract under microscope, you can see that these alveoli are perforated by the fibers, by the Charpie's fibers. These perforations make it like a bubble. So whenever you are trying to cut this bone, you have to take into consideration that this bone is not like a marble, it's not solid. It is little bit perforated. While you are drilling this one, it's not like enamel or dentine solid, or let's say enamel solid. It is perforated. When you try to trim some bone, expect that this bone is not a one piece, it's not one block, okay? And the more surprising factor is that these perforations are more in the cervical area more than the middle and the apical part, meaning that these perforations are more near the tooth rather than going more to apical. While you go middle third or apical part, you will have less perforation, which means that these perforations are closer to you in or during the surgery. And that is one of the factors. The other important factor is that we have some anatomical defect, especially in the anterior area, in the upper and lower jaw. We call it either dehiscence or fenestration. When you open your flap, you will see these two kinds of defects. And these are very important because once you reflect your flap, depending that you will cut bone and you face this kind of anatomical defect, you have to change your mind now. And you cannot take for every patient a cone beam to check exactly about this fenestration. It's not even justified. So just put in your mind that whenever you have a thin gingival biotap, you might have this kind of fenestration or dehiscence. And not only to know what kind of bone you have, also you need to know where is this bone, okay? We all know that we can use periodontal probe to measure the sulcular depth. But while you insert your periodontal probe, okay, you just only measure the sulcular depth. The bone is still away from that point, okay? And usually, you cannot do this. You cannot measure the bone without giving anesthesia for your patient. This area below the sulcus, okay, and we will talk about it later, is really sensitive and painful. You cannot do this. You cannot check where is your bone without giving your patient anesthesia. So you need to check where is the bone. We call it bone sounding. And in normal cases, the bone is situated about 3 millimeters from the tip of the gingiva. 1 millimeter sulcus, another 2 millimeters, we will talk about them later. In some of the cases, the bone is a little bit more coronal, while in other cases, the bone is a little bit more apical. So we have 3 variations. In order to do that, you have to use either periodontal probe or you can use this instrument, which we call bone sound. It's from Hugh Freddy. And in this video, you can see exactly how we can do that because this instrument, let me just raise the voice. This kind of instrument is a little bit curved, so it will adapt to the surface, labial surface of the teeth. Once you give anesthesia, the first millimeter is going into the sulcus, and there is a mark there. Okay, the second mark is a 3 millimeter, which is the normal distance on the labial area. It's a little bit different. Another mark is there because usually the proximal bone, mesial and distal, is a little bit even more deep. Or I can say it's not deep, it's on the same level, but because the papilla is going down, you can see that the distance that this instrument is getting inside is a little bit longer. So you need to know the type of bone that you have and put in your mind that there should be or could be some anatomical defect there. And also you need to know where is this bone. And in most of the cases, in order to know, after we reflect our flaps, in order to know where is the location of this bone, rather than keep using your periodontal probe every while and then, we have something called in-cutting pair, in which we use during our surgery to measure exactly these 3 millimeters. And the distance from this mark up to the tip is 3 millimeters. And this is a guide for us to go back again to the normal situation. We'll talk about this one later. The fourth concept that we need to know is the biological width. after we already discussed that there is a circular depth and there is another 2 millimeter to reach the bone. These 2 millimeter are called biological width. And the biological width usually is consisted by 2 compartments, which is either the first is the junctional epithelium, which is about almost 1 millimeter, and another connective tissue attachment, which is 1 millimeter. Body would like to respect these 2 millimeter. Okay. Anything you do during surgery, during healing after that, expect that the body will respect that 2 millimeter. What does that mean? Whatever you do, when the tissue heals back again, these 2 millimeter will be re-established. In order to be re-established, the bone itself, okay, has to be also away. Okay, so I will discuss 2 cases. In case you put your restorations inside the sulcus, and I will talk about it later, deep, and you go into the biological width, we call it violation of biological width, you will end up by a healing, but the bone will not resist that, and it will move away to create a space for this 2 new millimeter. We will talk about this one later. So this distance between the bottom of the sulcus until you reach to the bone is called biological width. And this is the situation that we are doing, most of the dentists, they are doing without putting in mind this factor. In most of the restoration, as you can see here, most of us tend to put his restoration finish line little bit subgingival. And this is maybe the optimal situation, as you can see now in the slide. We try to hide the margin of our restoration by hiding it subgingival. Up to a limit, maybe 0.5 millimeter, maybe 1 millimeter, you are lucky there, the biological width will be respected and nothing will happen. But what if you place your margin deeper by 1 millimeter or you just place your margin much deeper to reach the bone there? Most of us tend to place the margin a little bit deep, or when he just places his restoration or his finish line and places restoration, the margin of this restoration is inside the sulcus, but how deep it is inside? Is it only 0.5, 1 millimeter, or even deeper? And the reaction of the bone and biological width will depend on what type of tissue you will have. As we discussed, we have a thin biotype and we have a thick biotype. If you notice here, we have a restoration margin which is respecting the biological width. What if we place our margin to reach the bone in a thin biotype? And what will happen if we place our margin in a thick biotype reaching the bone? The body, as we said, will try to re-establish this biological width. And how it will do that? The bone has to run away to escape. So in the thin biotype, it will escape by horizontal bone loss. You will see that the bone is resorbing. But in the thick biotype, as it is thick, the bone will resorb, but more into vertical direction. So in the thick biotype, you will end up by having pocket, while in the thin biotype, you will end up by having recession. And it is an example, here's an example of cases in which you place your restoration into a thin biotype, much deeper, and then the tissue react by having bone resorption and recession. While in these cases, you place your restoration into a thick biotype, and what happened is exactly what most of us see in our daily base is inflammation, redness, and pocket. So the reaction of body depends on either it is a thin biotype or it is a thick biotype. And this is another concept that we need to respect, the biological width, okay? The fifth factor about this lecture is the gingival zenith. And what do we mean by gingival zenith? We mean by that is, what do we mean exactly is that the highest point of the gingiva on the central, lateral, and canine is different. When you need to re-establish a new margin, or you cut, or you want to do crown lengthening, the amount of gingiva you have to cut should respect this concept. This concept says that the highest point on the centrals, are a little bit distal and also on the lateral. So when you cut your gingiva, you have to respect that. You have to make it a little bit more into the distal, while in the canines, it's in the middle. Another factor, and this is a very important factor also, most of us do not respect or sometimes don't take into consideration. Most of us, if they are going to do any prosthetic work on a reduced length of any teeth due to root canal, broken restoration, broken crown, we aim to do some build-up by doing a cast post, or we do a fiber post. Yes or no? But most of us don't take into consideration something called Ferrell effect. And what is Ferrell effect? Ferrell effect is the amount of tooth structure that you should keep above the gingival line in order to resist the lateral forces during mastication. And I see many of cases came to my clinic in which the buildup is at the same level of the gingival line, and the finish line is exactly placed in a way that there is no suprastructure of the supratooth structure above it. And here you can understand my point. Most of us tend to place a post inside the tooth, but he didn't respect that Ferrell effect. And this Ferrell effect is very important all around the tooth. You should have a minimum of 1.5 up to 2 millimeter of tooth structure sound that you place your finish line, and you are really safe not to have any, let's say, crown removal or broken view restoration because of this concept. And in this slide is very important. Now, how we measure these things? You have to measure something called from osseous to crown margin distance. In order to understand this Ferrell effect, you have to put in your mind that there should be a 2 millimeter of biological width respected and another 1.5 millimeter of Ferrell effect respected, and a circular depth of 1 millimeter. Me as a periodontist would like to take another 1 millimeter of safety. We have 4 scenarios here. The 4 scenarios depends on where you will put your margin, either supragingival or subgingival, or is it a natural tooth or normal tooth structure, or it has a post and core. So if you have a supragingival margin and normal tooth structure, you will need 2 millimeter biological width and a 1 millimeter of safety, because you're already placing your gingival or finish line at the gingival line or above it. So you only need to respect the biological width here, okay? While if you have a post and core in the second situation, and you have a supragingival restoration or margin, you need to respect the 2 millimeter biological width and 1 millimeter safety and another 1.5 millimeter of Ferrell effect. I'm talking about the distance from the gingival margin here to the bone, okay? Now, what about if most of us place our margin subgingival? Most of the cases we just place this margin subgingivally. We have 2 types. We have either normal tooth structure, and we have cases in which we have a post and core. Sorry, this is wrong typing here. Supragingival margin, you will need a 2 millimeter biological width, 1 millimeter safety, and 1 millimeter of sulcus. While if you place your subgingival margin and you need a post and core, this is really big. You will need 2 millimeter biological width, a 1 millimeter of safety, 1 millimeter of sulcus, and another 1.5 millimeter of Ferrell effect. So you need to understand that you need to have a Ferrell effect if in case you have a post and core or you are making buildup. And amount of Ferrell is 1.5 to 2 millimeter in order to not having this restoration broken or fallen out. And this is a very important factor also. You have to respect while you are doing your crown lengthening surgery, because when you want to cut the gingiva and bone, you need to know that the distance from the bone to the gingival margin after you finish your surgery should respect that concept. Another factor is the crown root ratio. As we said already, we will cut the amount of gingiva and bone that we need, but we don't want to end up by unfavorable crown to root ratio. In these cases, if you into unfavorable crown to root ratio, this is not let's say a good result. We aim for a long-term restoration rather than just exposing to the structure to have crowns or veneers. And we have now another concept. We already discussed all of these 6 concepts. We will have another concept, which is the altered passive eruption. During eruption of teeth, we have 2 types of eruption, something called active eruption and something called passive eruption. Active eruption, in which teeth are going down to its normal position. Passive eruption is when the gum just go up cervically to expose this full tooth. In cases in which we have altered passive eruption, we will have the active eruption, but the passive eruption is not happening. Okay? And in this
eruption begins with active eruption, with the
understand
crown of the
it.
tooth fully emerging from the bone into its correct position. The passive eruption phase then takes place, where the gum tissue moves vertically to expose the full crown of the tooth. Altered passive eruption occurs when the crown of the tooth has fully emerged from the bone, but the gum tissue has not moved into the correct position. This leaves the crown partially covered by gum tissue and also results in a shortened appearance.
And by seeing this video, you understand my point that what we are going to do in the cases that we have gummy smile, most of the cases that we have gummy smile, we have many causes of gummy smile. And these causes are either, as we discussed in the previous lecture, are many. The only one that you can do with, or you can deal with crown lengthening surgery is the cases in which we have the altered or delayed passive eruption. Other causes like vertical maxillary excess or the detorqued or lingually tipped maxillary incisors, or the cases in which we have short lip, or the cases in which we have hypermobility of upper lip, has to be either referred or dealt by another treatment, not a crown lengthening surgery. Another concept, which is the post-orthodontic treatment and gingival fibrosis that happened after the ortho treatment. In most of the patients, they came to you to do alignment or closing the gaps in between teeth. And as you can see in my patient here, she don't have any, let's say, too much gingiva covering her teeth. But after we finished the treatment, added to that her little bit bad oral hygiene, we ended up by having this. And this is very, very popular in your patients. Okay? Usually the teeth move, bone remodel around it, and the gingiva follow. Okay? And the mood that gingiva will follow the bone, we call it fibrosis, because in these cases, once we reflect our flap, we can see these lines here. Okay? And these are the reason why most of the orthodontic cases that we put the patient a retainer, either fixed or removable retainer, because bone remodel while the teeth are being pulled by these fibrosis. Okay, and that's why I advise most of my patients who finish orthodontic treatment to do crown lengthening surgery to minimize the effect of relapse. This kind of fibrosis is very important while you also reflect your flap. In most of these cases after ortho, you will find that reflection of the flap on this patient is very difficult. And most of the time, I tend to do it by sharp dissection rather than with the periosteal elevator, because I might have tear if I just insist to elevate these tissues. So is laser enough in these cases or no, or not? I think it's not. After ortho, the bone will follow, the gingiva will follow. So you need to cut bone. Is laser is enough in these cases? I don't think so. Number 9, the golden proportion and ratio. before you start your surgery, before you start planning for this case, ask your prosthodontist, what do you aim for? What's your prosthetic plan? Because you need to end up by having a good proportion of teeth. Okay? And we all know that if we divide the normal central incisor or lateral or canine, if we divide the width over the length, we will end up by having a ratio between 75 up to 85%. We need to end up our surgery by having this proportion right. And also we have to take into consideration other factors in the shape and dimension of these teeth. As a periodontist, I might use this instrument, which is very helpful most of the time, in which maybe it saves me a lot of time measuring the width and length. If you can see in these cases, the width of the tooth is from the outer red line here and the outer red line here, while the length is little bit shorter from this. I need to cut little bit gingiva following this ruler. But I can tell you that I don't have, in most of my patients, it's not ideal. And in most of my patients, we need either to elongate the central incisors or follow the prosthetic plan. So these kind of instruments should be used only onto healthy tooth and normal tooth structure that you are not willing to increase or decrease into length or width.
Utility. Clinicians may encounter small, large, and extra large teeth. In such situations, the recommended measurements utilizing the central incisor as the starting reference point will move down one full band measurement both horizontally and vertically for small teeth, up one full band measurement for large teeth, and up two large band measurements for extra large teeth.
Okay, so we know that we need to consult our prosthodontist in order to know exactly what are the dimensions that he wants. And that's lead me to the last point, which is our plan should be restorative and aesthetic driven. We shouldn't cut like this. We shouldn't even start cutting without consulting our prosthodontist, or he give us his plan or guide what to cut and how much we cut. So that's what I'm telling you. In most of the cases, there should be a relationship between the prosthodontist and the periodontist, and a mock-up should be done, and you should wax up your case and give it to the periodontist in order to be used during the surgery to know exactly where is the finish line during the cutting. So, as you now already know all of these 10 concepts, you will now know and you will see that the objective of a crown lengthening surgery is either to treat the gum smile, in which the concept of altered passive eruption would be corrected, as we already discussed, or improving the aesthetics by correcting the zenith, or exposure of sufficient sound tooth structure like the ferrule effect that we discussed already, or correct placement of margin restoration without violating the biological width. We have cases in which we have all veneers or crowns placed too much deep into the biological width and being referring to us to correct this invasion. Or sometimes we treat gummy smile cases also to correct the golden proportion. So different kind of treatments for crown lengthening procedures. And most of the dentists in their clinic would like to choose the easier, but most of it, which is the laser, or maybe using just only the blade without doing the osseous surgery. But I can tell you from my experience that almost 90% of the cases will need some bone modification. And this kind of bone modification will keep your result a long-lasting result. So in my clinic, I tend to use laser only 10%. I respect laser is really useful, but if you would like to have a persistent result that can really last long, you should start thinking into more dealing with osseous surgery rather only than doing only laser surgeries or laser cutting. In this lecture, I'm going to discuss the concept of osseous surgery. I'm going to discuss the concept of osseous surgery and I'm going to discuss only the concept of gingivoplasty or cutting of gingiva and osteectomy or cutting the bone. I'm not going to discuss the laser or electrosurgery or cautery. I'm not going to discuss apical position flap. It's a little bit more advanced, need a different course. We will discuss a little bit about orthodontic treatment with surgical treatment. So if you really understand this concept, now you can start. And let's start. First of all, we said that we need to, before we start, we need to assess the case by knowing exactly where is our bone. And then if the bone is very close, we need to cut bone. Very close meaning that we have 3 millimeters or less. And if we have bone which is really high, which is away, when we do the bone sound, it's more than 3 millimeters, then it's maybe not an osseous surgery. And these are the cases in which I'd like to use maybe laser with caution. Going back to this concept, if you do bone sounding before you start, you need to know exactly where is the bone. If you have the bone very near to you, less than 3 millimeters or 3 millimeters, some of the cases you need to cut bone, while if you have cases in which the bone is really deep, maybe you will not need to cut bone. The second assessment is the kind of tissue that you have, attached gingiva, tissue biotype, all of these factors have to be taken into consideration. But what if we have less than 3 millimeters of attached gingiva and still you need to do crown lengthening surgery? It's not an option right now to cut gingiva. You need to move your tissues more apical. You need to do something called apical position flap. While if you have more than 3 millimeters of attached gingiva, you can do your either cutting by laser or cutting by blade and then osseous surgery. So the second important factor is the bone. And when we start our treatments for these cases, we all know that either we are going to deal with altered teeth structure, I mean that already or previously treated or having crowns or veneers before, or correcting restoration in which we have the margin violating the biological width, or we need to enhance retention of short restoration. Patient came to you telling you that these crowns keep falling, and that's why we don't have a ferrule effect. Or we are dealing with cases in which we do have non-altered teeth structure, which means that patients want to do crown lengthening to treat either the gummy smile or incorrect gingival margin, incorrect gingival zenith, okay? And if he has excess gingival display because of either using medication or let's say some kind or type of diseases or after orthodontic treatment. So in these cases in which we have either violation of biological width or old veneers, we need first to remove the old restorations. While in these cases in which we have natural teeth and the patient is asking for the treatment of the gummy smile, we are dealing with non-altered teeth structure. In these cases, after you remove the old restoration, you will be surprised by seeing redness, calculus underneath the restoration, a little bit, let's say, more inflamed tissues. And after treatment, you should end up with having a correct dimension of your restoration and hiding the gummy smile that the patient have. In this case, we shortened a little bit the centrals. As you can see here, the centrals are a little bit longer. We little bit shortened them in order to manage the case. While in this case, we just only dealt with the gingiva and bone with no restorative option in our mind. But we ended up by having some composites here on the incisal edge. Or we have cases in which the patient has already old veneers and gummy smile also on the sides, in which he has old veneers in the front teeth has to be replaced, and also on the premolars he has short crowns. And in these cases we did the crown lengthening to correct the gingival line and to end up with a result like this. So you should first, as you can see here, you should first have your prosthetic plan. You should know where you are going by doing mock-ups, by doing waxing up your case. So after that, you can really start and really know how much I need to cut. Is it available or not? Do I have attached gingiva or not? Do I have bone very near to me or not. It is a mix of planning the case and at the same time knowing the right concepts. And in most of our cases, in most of our patients who came to our clinic, they came and asked for a prosthetic or let's say a smile makeover. And this is a point in which we shouldn't jump or shouldn't feel very happy, okay, and start immediately doing the veneers or crowns. We should start by having a good treatment plan, respecting all the concepts that I told you before you start the surgery. And this is exactly what happens maybe in my clinic. When I have a patient coming for smile makeover or veneers, everybody is shouting veneer in the clinic. Even in the outside, in the street, everybody is shouting veneers. It's a patient for veneers. But actually, in most of the cases, it's not only veneers. It could be orthodontic treatment. It could be veneer treatment. So as I discussed with you, I will be dealing only with two kind of, let's say, procedures. The first one is the, I call it osseous crown lengthening surgery. And the second one is using a little bit of orthodontic treatment in which we do extrusion of the teeth and a little bit of fibrectomy. I will discuss it later. Let's start by the concept of osseous surgery. While you are holding your blade, you should know exactly how to hold this blade. Should you hold it in this direction or this direction? How you hold it exactly, what angulation you should hold it. And in most of these cases, when I do courses, I just, let's say, focus more on how to hold your blade in these cases. Because in order to start a crown lengthening surgery, you should start by cutting the gingiva in a right way, in a right bevel. So you will end up by a nice result at the end, okay? We start our surgery most of the time after we define how much exactly we need to cut from the gingiva and from the bone. We start by something called inverse bevel incision or reverse bevel incision. Okay? And this is the first incision you need to do in your surgery. You should direct your blade into the root direction, apical direction, okay? Mark exactly where is the point that you want to cut and do your cutting in a way that is more beveled or the blade is directed more to the root direction. So you hold your blade, okay? And actually I don't like using 11 in most of these cases, but 15 or 15C even. And even I don't like to cut the vertical incision here. So the first incision is to, as I told you, number one here is to do the internal bevel incision. The second incision is the sulcular incision. So, or clavicular one. You cut from one side, you cut from the other side, reaching to the point in the bottom here. And then you need to remove this kind of tissue. I will discuss it later during the procedure. So you have the first incision is called internal bevel incision. You should hold your blade into the root direction, into 45 angle, and cut exactly the amount of tissue that you need. And then the second incision should be inside the sulcus, reaching to the same point that you cut from the top, meeting in one point, and then you should remove the tissues here. So let's do a clinical test together. We have Zahra here. Zahra, she came to me and she wants to enhance her smile. And it's very obvious that this case is mostly after doing the orthodontic treatment. In Zahra, I need to discuss all the points that already we discussed. We have a good band of attached gingiva. Okay. And we have a thick biotype. We have gingival zenith, which is not respected, or let's say not well formed in most of the teeth. The highest point here is in the middle. Here it's a flat point. What else we have? We have a thick bone here, a very thick bone. And that's why we will see, we will not only cut the marginal bone, we will also reduce part of the labial bone. Okay? So, for Zahra, what we did exactly? We did a bone sounding, okay, to know exactly where is the bone. Okay, and by doing this with the normal periodontal probe, you can notice that the bone is really near. And after that, okay, I give the patient my anesthesia, and then I really go deep to check exactly where is my bone. Okay, and then I use my instrument and check exactly what is the gold proportion for this tooth. Sorry. I mark exactly how much I want in order to reach the right proportion in this patient. Okay? And after doing that, I use the chew instrument in which I exactly determine my width and length. I mark the points where I should cut. Okay? I know where is my bone. It's very near. Then it's an osseous surgery. I need to reflect flap and cut bone to place the bone away. This is my first incision. After I mark all the points, I make my first incision with the internal bevel. And as you can see here, if we repeat that, the blade is directed to apical direction. Okay? So this is the first incision. Okay? The second incision is the clavicular, which is inside the sulcus. And now these 2 points meet in a 1 point. And this tissue has to be, okay? So first incision was internal bevel. First incision was internal bevel. Second incision was clavicular or sulcular incision. We meet into 1 point, we take this excess tissue out. And this is how we ended up by cutting only the soft tissue. These are the right proportion, okay, that I want in this case. What if I stop there and say to the patient that I finished? What will happen? Because the bone is really near to you, and it's really near, okay, the tissue will grow back again. Because as we said, the biological width has to be restricted. If you came near the bone, the tissue will grow up back again, and it will come back down again. That's why in most of the cases that you do laser surgery, if you do laser, which is exactly the same steps that I'm doing here, by cutting with laser, you are doing the same step here. If you stop there, what will happen? And you tell the patient to go home, you finished already, and you get your right proportion, and the patient will like the result. What will happen? The patient will come to you after maybe 4 to 6 months or even less, having his tissue grown again back to its original position. And why is that? Because we didn't cut bone. Now, once we cut the tissue, we violate the biological width. The body tends to re-establish the biological width again. Another 2 millimeters of tissue will grow, and you will have your overgrowth again. So what's the next step? The next step is a flap reflection. You need to start reflecting your flap in the papilla side, in papillary areas. Once you finish all the papillary area, don't make it very fast, because flap reflection is the most crucial part, or let's say step in this kind of procedures. If you keep pushing your gingiva hard, you will end up by having tearing. And here I would like to insist and go back again that in these patients, they have gingival fibrosis after orthodontic treatment, which means that blunt or periosteal elevation alone will not be enough. You will end up by having tearing. You need to do some sharp dissection. Otherwise, you will end up by having tearing. And then I start reflecting the flap in all the areas. Okay? Sorry. And then, sorry. So, and then I use my end cutting pair, the one I told you about. And here I start cutting the marginal bone. And how I know exactly how I should cut? I should measure from the cervical line, 3 millimeters, and cut all the bone there. How I know while I'm doing drilling? By using the in-cutting pair. In-cutting pair has a mark here, which is the 3 millimeter mark. If I put it on the cervical line, there's another 3 millimeter in the pair. there is my limitation in bone cutting. And remember, when you cut the bone, you should follow the same cut that you made in the gingiva. So you should even respect the zenith in the bone cutting itself. And here is a very important step, and I don't advise most of you who didn't even try this procedure to do it alone. It should be maybe under supervision, or he should be a little bit more trained to it. Here, after I finish cutting my marginal bone, I should little bit reduce the thickness of the labial bone. And why is that? Because in these patients, they don't have only growing bone coronal, they have also bulkiness of bone labial. And this bulkiness of the bone will, let's say, make the case of gummy smile more worse. If you cut this part of bone, or let's say trim it, reduce the thickness of this labial bone, you will have less resistance on the lip. Or let's say the lip will be more relaxed. Imagine if you have a thick bone, the lip is here, and you are trying, the lip is going up, because of the bulge here of the labial bone, the lip will jump over that and more tissues will be exposed. If you have a flat bone, the lip will be more relaxed and it will move easily. Okay, so this bulge will help a lot on the patient profile and patient smile. And after that, I use my special instrument, bone file, another one for the interdental area. And then I use another thick bone file for the labial bone to make it more smooth, not to have any spikes. And now the most important, let's say, a step, which is suturing. If you open a flap from 5 to 5, it's not easy for you to make single interrupted suture in all the areas. Here, we'd like to use the continuous sling suture, okay? In this continuous sling suture, as you can notice here, I jump from one papilla to another, and by doing this, I put less tension on the papilla, and it is more aesthetic even for the patient, and he can go home without having any knots, let's say, shown in the patient mouth while he's smiling. بالعربي لما بتعمل هاي النوع من انواع السوتشرينج، انت حتنتهي عندك عقده واحده على اليمين وعندك عقده واحده على اليسار، ما في اي نوتس او عقد على الليبيال اريا، وبالتالي المريض بيروح على البيت ما عنده سوتشرز مبينين. هي اول نقطه. ثاني نقطه، السوتشر هذا بيعمل ليس تنشن على البابيلا، وبالتالي more or prefer healing. Okay. Now, if you would like to have let's say, more information about the continuous sling suture, you just can Google it, or you can just watch it on YouTube. But this is a kind of suturing that I do in most of these cases. So the same patient, immediately after the surgery, and this is the result after 1 month. Let's have another case. Again, let's go back to our factors, in which we measure the attached gingiva. It's a good amount of attached gingiva, a thick biotype, not good gingival zenith. Okay, I need to measure my bone. Where is it exactly? By doing bone sound. And then, as the patient is not willing to do any prosthodontic treatment, I can go on. In this case, I follow the same steps. I mark my points according to the dimension that I want. I start cutting, and I ended up with now like this, without reflecting any flap, ended up by having the right proportion that the patient liked. And the patient are very happy with that result. But shall I leave him to go to home without continuing my procedure? No. I need to start reflecting my flap, exposing the bone, and going back again to our dimension to know exactly the right dimension that I need, and then cutting the marginal bone, using the bone file, same steps in all my patients, and then ended up by contoured bone cutting like this, scalloped labial surface, immediately after surgery, and 1 month after the surgery. Only crown lengthening, whitening, and I think we did composite in this case. Another case, same steps exactly in dealing with gummy smile patients. Same steps exactly. We didn't change any step. Going back to the concept one by one, ending up with results like this. And you can notice in this patient, not only cutting the gingiva and bone here, give me this end result. Also reducing the amount of bulky bone on the labial surface will give me a more relaxed lip, as you can see. Okay, and better patient profile. Another case, again, evaluation of the points. We have, let's say, gummy smile more on the sides, and then the patient decided to, this is immediately after surgery, and this is 1 month after with some whitening and composite fillings. And another case here in which the patient came for veneers, and you shouldn't jump into veneers in these cases very fast. You should evaluate your case with the prosthodontist. You should evaluate exactly by doing mock-up and wax-up for your case, knowing exactly where you are going, and telling the patient that you will have a veneers which is the same as your teeth, but just closing the space, and it will look even wider. In these patients, we promise them that you will have an end result which is really good, and it will last with you without having any smell, any bad, any bleeding or pocketing. And this is after crown lengthening surgery, and this is after composite, not even veneers. This is a composite fillings. And what if we just place composite in this case without doing the crown lengthening surgery? You will end up by having wider crowns. So again, proportion are respected, and you end up with a prosthetic result or restorative result, which is really nice. Another case after orthodontic treatment in which we have overgrowth of the gingiva here, thick biotype, all of the teeth have proportion which is not right, zenith also is not right, but we decided to do crown lengthening surgery, and this is the result. And much of cases after and after. Most of these patients are really happy with the results. What are the post-operative medication and instruction you should know, and you should tell your patient? First of all, you need to know that sutures has to be kept there, but not for long period, maximum 7 days, okay? Because if you keep the sutures there, on the place of or point of the suture, or the suture, it was inserted in every place. Because of the continuous sling suture, you will have like dots. So you have to remove your sutures the fastest, 4 to 7 days. And you have to give your patient non-steroidal anti-inflammatory as a painkiller, if it is indicated or not contraindicated with other medication. And also, in most of my patients, this is an osseous surgery. It's like a wisdom tooth extraction. It is a little bit more traumatic. So you need to give your patient something that will reduce the post-operative complication. In most of my patients, I give dexamethasone IM injection, intramuscular injection, 8 milligrams. And if I'm going, or this case is referred to me by a prosthodontist, he know, and I inform him that please try your best to temporize your case for at least 4 months before taking your final impression. So what is the difference between doing a crown lengthening for a natural tooth and a crown lengthening for a tooth in which you are going to place a veneer on? As we already discussed, we need to do a prosthetic plan, mock-up and wax-up. But the 3 millimeter that we need to cut bone depends. If it is a natural tooth, we will measure it from the cervical line and 3 millimeter. If it is a veneer or crown, the margin of your restoration, future restoration, should be away from the bone 3 millimeter. That's why in natural teeth, we can use the chew instrument, while in the cases we will have veneers later, we prefer to have a mock-up that we will place in patient mouth to aid us to know how much exactly we need to cut. So we have both cases, either aesthetic crown lengthening or functional crown lengthening. And we discussed already that in functional crown lengthening, we not only care about aesthetics, but we also care about retention. And in most of the crowns that need to establish a ferrule effect, we should have this ferrule all over the teeth. While in aesthetic crown lengthening, in which you have natural tooth structure, full natural tooth structure, most of the time the cutting it will be only on the labial. And the cases in which we will have, or we need to have a ferrule effect, we need to cut 360 degrees. What most of the cases that it comes to you, sometimes you have a patient in which he has a discrepancy in one or two teeth, not the full segment. Okay, and another factor to take into consideration in these cases, if you are willing to do crown lengthening in these cases, okay, you should know that if you cut the gingiva, you might end up with having asymmetrical results. If you cut from one tooth more than the other one doesn't need any crown lengthening, and this tooth, it needs crown lengthening either because of gingival discrepancy, or you need a ferrule effect, you need a tooth structure to gain retention of your future crown. Then if you cut more gingiva here, you will end up with having discrepancy. Okay? That's why in most of these cases, we might ask the help of our orthodontist, and he can do something called extrusion, in which he will extrude the tooth out of its socket, but at the same time, we need to do some fibroectomy. We need to cut the gingival tissues while he's trying to, every week or every 10 days, while he's trying to extrude his tooth out of the socket, we will just cut part of the gingiva so that the tooth will come down without the gingiva with it. And in these cases, we should take also into consideration other factors, like the root length. If I extrude this tooth out of the socket, am I going to end up with an unfavorable root to crown ratio? And also the root form. If the root is really conical, the tooth might get mobile. And also the level of fracture. I can extrude the tooth out of the socket, but up to a level. If there is a vertical root fracture, I shouldn't be a hero and keep pulling that tooth out of the socket. And also the endodontic situation and restorability of this tooth. Okay? Thank you so much. I hope I already explained most of the points that we have. And I wish that in this lecture, you at least understand the points that you need to know before you start your surgery. In these kind of procedures, it's a little bit sensitive because whatever you cut from the tooth, from the gingiva or from the bone is not reversible. If you cut 1 or 2 or 3 millimeter of gingiva and you shouldn't cut that, it is not reversible. So please take into consideration all the points that we already discussed in this lecture. Because if you don't, you might end up with results that really is a disaster to your patient and disaster for you. All of these points has to be taken into consideration. And don't jump on holding your laser or holding your blade without knowing all of these factors, or study these factors with your patient case by case. Cutting gingiva or cutting bone can be done, or you can train yourself on it patient by patient, but you need to understand why you are cutting this amount and how should I cut and how should I close my surgery in order to end up with the same result, persistent result all over your patients. Thank you so much. And I will open, let me just check. Okay, you can raise your hand and we can accept some few questions. I will try to answer the most of you, but we'll try to answer the, so we'll start by Dr. Karim. You hear me?
Yeah, hello, doctor.
Dr. Karim?
Yes, I hear you. Can you hear me?
علي صوتك لو سمحت شوي.
You can hear me now?
Yes, I can hear you. Go on, please.
In case if we have less than 3 millimeter of attachment gingiva,
Okay.
what's the best solution? How we can flap the gingiva?
Yeah, in these cases, you will do your osseous surgery, but you will not do gingival cutting. You will just reflect the tissues and suture your tissues into more apical situation. In these cases, we call it apical position flap.
Okay.
First step, which is inverse bevel incision and say clavicular incision, you will skip it because you want to preserve your attached gingiva. You will just only do the clavicular incision, reflect your flap, cut your bone as we already know, and then suture your gingiva into more apical position by using vertical mattress.
Thank you.
Most welcome. Sorry, we'll allow Dr. أشرف.
السلام عليكم.
وعليكم السلام. أهلا دكتور.
الله يعطيك العافية دكتور محمد على المحاضرة الجميلة.
حبيبي الله يخليك.
دكتور عندي سؤال معلش. In case of I have patient, okay, I'm a periodontist resident by the way. I have a patient with altered passive eruption with a high smile line. So in this case, what do you think the management will be? Do we need to do only the aesthetic crown lengthening without applying any Botox injection or lip reposition after that?
تمام سؤالك واضح. الباسيف eruption usually احنا we deal with it يعني in a different way. هلا الالتر باسيف eruption if it is a young patient والorthodontist عم بيعالجه usually we should wait for the end result of the orthodontic treatment and then start treating the altered passive eruption. هلا في other causes زي ما انت حكيت. انا عندي محاضره على الصفحه على دنت ارت اكاديمي على ال other causes of gummy smile اللي منها مثلا vertical maxillary excess او عندك let's say short lip او عندك hypermobility of upper lip. You could use other kind of or let's say maxillary anterior incisors شويه proclined. You can do other or refer to other specialists. احنا بنتكلم مين اللي احنا كدنتست ايضا بنعالج gummy smile او بيريدونتست سي اذا بنعمل اشياء بالعياده، ايضا بنعالج الجامي سمايل كيسز ديو تو التر باسيف ايربشن اور الكيسز اللي فيها بروستاتيك اللي هي الفينيرز والكراونز and we want to enhance the patient's smile by doing the crown lengthening.
الله يعطيك العافيه دكتور. معلش البيشنت she doesn't want to do any prosthetic treatment, only she want because she has a short crowns, okay, and she's not planning to do any ortho or pros or anything.
اوكي هلا اذا حتسوي periodontal treatment صح؟ حتسوي crown lengthening.
Yes.
Okay, if she's going to do crown lengthening procedure, usually we start by doing crown lengthening surgery, getting the teeth back again to proportions, and if still she has gummy smile, we'll go for to look after other causes. أنا زي ما حكيت لك دكتور في عندي على الصفحة already محاضرة كاملة على الgummy smile. عندنا option of having
شفتها حضرتها دكتور.
في عندنا option of having Botox to minimize that. في عندنا lip repositioning surgery. We have many options to do, but first of all you should start by يعني correcting of the altered passive eruption, correcting all the anatomical tooth structure, and then start doing other kind of procedures.
معلش دكتور محمد سامحني بس سؤال اخير ان شاء الله يستفيدوا حتى لكل المستمعين. دكتور انت ذكرت في نقطه بعد ما to raise الفلاب. طيب how to cut البون انه انا واجهتني مشكله صراحه انا عندي الانكاتيفير بس انه ما اعرف اوكي انا بشيل مثلا 3 مللي بعد ما سويت البون ساوندينج كل شيء بشيل 3 مللي بس بعد ما افتح الفلاب او ارفع الفلاب ايش الريفرنس عندي؟
اذا natural tooth structure your cervical line
اللي هو السي اي جي دكتور قصدك ولا؟
نعم.
الله يديك العافيه دكتور شكرا جزيلا.
اهلا دكتور شكرا. اوكي دكتورة سلمى. دكتورة you hear me?
Hello, I can hear you. Hi. My question is, what kind of sutures do you use with this operation when you do the sling sutures?
I use all other sutures except black silk because of the hygienic purposes. Usually black silk accumulate food after that and it's really not hygienic for the patient. For these cases, as you saw on the video, I use nylon 4O. nylon sutures.
Okay, thank you.
Most welcome. Dr. Silma already done. I will lower all hands. So if you still have a question, please raise your hand. Okay, Dr. Mohammed Akwil. Can you hear me? Doctor?
Hello.
أهلا Doctor.
Can you hear me?
Yeah, I can hear you. Go on.
Yes. First of all, I want to say that thank you so much for the lecture. And my question is it necessary that the osseous surgery can be done in all the cases, or we can leave any case without the osseous surgery?
If you do bone sounding and your bone is more than 3 millimeter, you don't need to, and the amount of tissue that you will cut will end up again by having more than 3 millimeter, then no need to cut the bone. My issue is that after I cut the gingiva, what is the distance between your gingival margin and the bone? So you need to end up by having a bone sound which is 3 millimeter away from your gingival margin after you cut the gingiva. You understand my point?
Yes, sir.
That's why this is the distance in which you will decide to cut bone, or you only end up by having a soft tissue surgery, or let's say a laser surgery. After you cut your teeth according to the right proportion, in which the width over the length is right, then do bone sounding again, and the distance from your gingival margin to the bone should be 3 millimeter or more. Okay?
Yes, sir.
That distance, you don't need to do osseous surgery. If you have less than 3 millimeter, the tissue will grow back again.
Yes, sir.
Okay, thank you.
Yeah, thank you so much.
Okay, Dr. Okay, I can see Dr. Ibrahim. Hello.
Hello, Dr. Mohammed. Are you hearing me?
يا بس إذا بترفع صوتك شوي لو سمحت.
Okay. Are you hearing me now?
Still والله واطي كثير.
Oh, wait. What about now?
I need better. Okay, go on please.
Okay. Thanks for this lecture. And my question is, in the severe gum smile, sometimes we make gingivectomy, and sometimes we need to make lip reposition. What's the rate and success of lip reposition for these cases?
See, this is an aesthetic lengthening, and usually a different lecture for lip repositioning. Usually the lip repositioning, I do it after I finish my, not in the same visit. I do my crown lengthening surgery, and then in the follow-up visits, I ask the patient if he still needs to do that, and then we do lip repositioning. The only problem with lip repositioning is that it relapses. Usually in most of the patient, it relapses after maybe 9 to 12 months. If you are lucky, maybe up to 1.5 years. So this is the problem with lip repositioning. But I don't do both procedures at the same visit. It's a disaster. Don't do that. The only good thing about lip repositioning, it might, let's say, give you a good results. But the bad one is the relapse. And sometimes you will end up by having a scar in which if the patient has high lip line, sometimes maybe it will persist for a long time.
Yeah. It is not permanent treatment.
No, it's not a permanent one. And I inform my patient and I take consent from them that you know already that this procedure is a relapsing procedure, that it might, maybe the gummy smile might relapse after maybe 9, 12 months or up to 1.5 years maximum.
Okay, Doctor, please. Is there any complication after lip reposition in the future, inshallah?
Inshallah, we will try to do any lecture in the future, because this is a different topic and in which you really need to be, let's say, focusing more on this procedure rather than factors to be discussed, because you shouldn't go for lip repositioning without doing a proper aesthetic crown lengthening. I mean, if you have a short crowns and you jump into lip repositioning, this is not right. So you need first to know that you don't need to do crown lengthening. You already have a golden proportion, the teeth proportion are right, and then you decided to do crown lengthening surgery. Sorry, lip repositioning surgery.
Okay, thanks, Dr. Mohammed.
Thank you. Bye-bye.
Thanks.
I think the name is Jink Tahiri. Can you hear me? Hello? Okay, not available. Okay, again, please raise your hand in case you want to talk. Okay, Dr. Dua. Can you hear me?
Hello, dear doctor.
Hello, can you raise your voice, please?
Hello, doctor. Thank you for the beautiful presentation. I have a question about, can you hear me now?
Yeah, if you can raise it even more, will be better.
Okay. Thank you for the beautiful presentation, but I have a question about during gingivectomy, before we are doing the gingivectomy and assessment of the amount of the gingiva we are needing to cut. How we can be sure that the limits of our cutting is correct? Because sometimes it's not about the golden proportion, it's about short crown. Naturally, it's a short crown. How we can do the gingivectomy without causing cement to enamel junction exposure? Sometimes the cropping is inaccurate.
See, again, you have a short crown in which you want to do a crown over it, or a short crown, I mean altered passive eruption. يعني انت عندك بالعربي دكتوره؟
اي نعم.
عندك سن كامل واللثه طالعه فوقه، ولا انت عندك سن مكسور اوريدي بتحبي تطوليه؟
لا naturally هو short crown. Naturally it's short crown. اعتقد هو passive eruption.
Altered passive eruption. Your reference point is the cement to enamel junction دكتوره.
نعم، لكن بالpropping when we are doing propping it's invisible underneath the gingiva, so sometimes the propping is inaccurate. Just the propping is inaccurate to determine whether is this limit is perfect or not.
عليك بهالحاله هاي اذا انت لسه يعني not sure, you might cut 1 millimeter by 1 millimeter. If you have a laser, okay, or you can cut the first millimeter and check back again, cut again another 1 millimeter and check back if it is really not sure. But I can tell you one thing, that in most of the cases ده يعني width على اللينث دكتور بيطلع مظبوط. يعني انت حتى لو الاسنان صغيره, if you divide the width of the length, it will give you most of the cases, 90% of the cases it will give you the right dimension. بس اذا انت not sure او يعني شويه متخوفه, you can start by cutting يعني 1 millimeter by 1 millimeter and keep checking it اذا هالدرجه متخوفه يعني.
Thank you so much. Thank you.
Most welcome. Most welcome. Again, I think Jink. Can you hear me? Hello.
Hello. Can you hear me?
Yes, I can hear you. Go on, please.
Thank you for the great lecture. I want to ask you something. I'm a young general dentist, and I've recently done some gingivectomy, not by cutting the bone, but just some soft tissue, you know. But as I hear you, there's a lot of patients who need some surgery, not just gingivectomy, as I heard. I don't know if I'm right.
Most of the patient, if you do bone sounding and you find the bone is really near, if you cut the gingiva, you will have the tissue overgrowth again.
So in this case, I have to ask if we as a general dentist have to do gingivectomy or should refer to the periodontists.
Just very simple, doctor. Just do the bone sound. Just give your patient infiltration anesthesia with your probe, simple periodontal probe. Just sound where is the bone exactly. This bone is 3 millimeter or more, and you would like to do your gingivectomy with laser, you can go on. If the bone is 3 millimeter or below, if it is maybe more favorable to you to refer, it will be maybe better.
Okay, thank you very much. Bye.
Welcome. Welcome. And the last one, I think, let me just check. Okay, please raise your hand again. Okay, sorry. I have Ahmed. Ahmed?
Yes, sir.
Ahmed Al-Asmawi, your name?
No, sir. It's Muhammad Akil.
Yeah, sorry. Fadal, yeah, you can go on. You already asked me.
Yeah, I asked.
Okay, maybe you should mute your microphone. Thank you.
Oh, yes, thank you, sir.
Most welcome. I think Dr. Haifa Ahmed. Dr. Haifa. Okay, Dr. Ahmed, can you hear me? Okay. Okay, thank you everybody. I will try to answer all of your questions and comments on the Facebook. Hope you already enjoyed it. I will keep the lecture there for a while. If you miss it or you would like to revise